Hi, folks. I want to begin by thanking Ned, the academies, the roundtable, the planning committee, my co-panelists. It takes a village. I also want to do a welcome to folks that are participating by webinar, and I'd like to do a shout out to my folks in New Mexico. Hola. Let me also say this is not my normal hair. I come from the high desert of New Mexico. So today I'm embracing my ethnicity because my curly hair is curly, which I think is okay. So Con Alma is Spanish. See if I can work this. There we go. Con Alma is Spanish for heart and soul, and that's our tagline, is the heart and soul of health in New Mexico. There are many similarities actually to the two presenters that preceded me, in that we are also very community-based, we're also community-led. And as Ned described earlier, our mission is to be aware of and to address the health rights and needs of the culturally and demographically diverse people of New Mexico. So that really is our focus. Our work includes grant making and beyond. So although we are predominantly a grant-making organization, we also do a lot of work that enhances that, and we are a private foundation. Our focus is on culturally diverse, rural, and tribal communities. New Mexico is a majority minority state. It's about 50% Hispanic, about 10% Native American, 3% African American, and other ethnic and racial groups. All of our work is done from a multi-field and multi-sector perspective, all of our work. So like this three-legged stool or table, one leg is the public or governmental. A second leg is the business or for-profit sector, and the third is the nonprofit sector, which includes philanthropy. And we believe that it takes all three legs to support this table of community. So we do not work in isolation. We do all of our work from that framework. We do our work also from an assets-based perspective, and we fund only systems change. We do not fund direct services. One of our primary strategies, which is the focus of this particular panel, is leveraging resources, and we do that very well. So here are a few examples. One is we partnered with Grantmakers in Health on the State Grant Writing Assistance Fund, and I believe that GIH got some funding from the Robert Wood Johnson Foundation. We matched the funds locally, and we put together a pool of grant writers that we made available to state, tribal, and county government. Just one of those proposals brought in $34 million to New Mexico, not to Con Alma, but to New Mexico, to help plan the health insurance exchange. We also have just completed a 2-year assessment of the impact of the Affordable Care Act in New Mexico from a health equity perspective. This was a collaboration between Con Alma and the Kellogg Foundation. We also partnered indirectly with the Colorado Trust, which Nick runs, in terms of using their report as a model for our own. And both of those reports are available on our respective websites. A couple of the funders collaboratives that we've been involved in include Hispanics for Philanthropy. We worked with them for many years in terms of strong Latino communities, and more recently, the Latino Men and Boys Initiative. Through that collaboration, we awarded close to $2 million to New Mexico nonprofits. And again, this was a collaboration between the National Hispanics in Philanthropy and the New Mexico site, which included CONALMA and other local funders. CONALMA's contribution was probably no more than $25,000. So again, it's through working together that we were able to leverage those resources. We also had a 3-year initiative called Healthy People, Healthy Places. That was supported by a national group of funders, a group of New Mexico funders, and then CONALMA put in 1/3 of that funding. And what we did on that, there were a number of reasons we did it, but what CONALMA was doing is expanding our definition and our work in terms of health equity beyond the ethnic and racial, which was the basis of our work. We expanded it for equitable built environment and food access policy, which we have continued. And I don't think, well, yeah, Tom, are you here? We have also worked with Tom and his organization and other groups in terms of public-private collaboration between philanthropy and government, and I hope that work continues. So the public-private collaboration is a critical part of the leveraging resources. In terms of our grant making, as I mentioned, we don't fund direct services, only systems change. So these are just a few examples of that. So we have supported legal advocacy. The New Mexico Center on Law and Poverty has been very successful in New Mexico in terms of winning a number of cases against state government. And I remember I went to a cabinet meeting, and one of the cabinet secretaries pretty much attacked me and said, "Why are you funding these nonprofits that are suing us? Why are you against us?" And my response is, we're not against you, we're in support of people and communities. Another area is workforce development. So we have supported community health workers, or promotoras, in New Mexico, and this is pretty much a kind of unique program to help develop our workforce from culturally relevant. These are people in the community that become part of the health care team, and it's done from a, again, culturally relevant, linguistically appropriate perspective. And in New Mexico, there was a Community Health Worker Certification Act passed in 2014 that now allows the community health workers to receive reimbursement through third party. Our small grants support economic security and stability, and we have funded a number of efforts in terms of affordable housing, particularly for children and families. This slide shows some of our foundational elements as a health equity organization. First among those is community self-determination. As a funder, we are not prescriptive. We encourage the community to determine what the needs and the issues are, and our job is to match our resources with those community needs. We value diversity. I am Hispanic. Some call us minority. I don't see myself as a minority. In New Mexico, we've always been the majority, and I'm certainly not a disparity. And we support preservation and enhancement of cultural and spiritual assets. Everything we do is asset-based and community-based. We focus on health equity versus health disparities. We define health very broadly. It includes the traditional and non-traditional, behavioral health, oral health, environmental health, spiritual health, and well-being. And, you know, we believe, even though we're a health foundation, that health is much more than health care. And that's why we fund things like, you know, housing and transportation, economic development, et cetera. And we have a shared leadership model. In the late 90s, there were a number of health conversion foundations. These are foundations that were set up when health systems, either health hospital or insurance, converted from being nonprofit to for-profit. The assets have to stay in the nonprofit world. So CONAMA was started with $20 million. This is a little bit more in terms of our shared leadership model. So we actually started our Community Advisory Committee, or CAC, actually preceded the development of our Board of Trustees. Our CAC provides input. There are community ambassadors, needs assessment, community outreach. We have a traditional Board of Trustees in terms of fiduciary, legal, et cetera. But I think what makes us different is that we have a shared leadership model. So every single committee we have, executive, finance, grant-making, planning, et cetera, they are all comprised of CAC members and board members. We also have a joint annual board CAC meeting, and those two groups are involved in financial oversight, strategic planning, evaluation, grant-making, policy. So this is a truly integrated model, and that's why I said when I started that we are community-led and community-serving. I am a recovering academic. I'm a former dean and professor, and so one of the practices I had and that I tell my students is there's no one definition on anything. These are a couple of different ones. We basically believe that health equity is where everyone has the right to good health regardless of zip code or skin color. This is a slide in terms of the difference between health disparity and health equity. And again, everything we do is from a health equity framework, not a health disparities. And some of the elements of this is that we really believe that in addition to kind of traditional approaches, we really want to focus attention on the systemic issues versus individual, which is often related to health outcomes, and look at those social conditions that affect health outcomes. Here's just a kind of baseline description in terms of some of the areas we work on, social conditions. And this should say, it doesn't, but it should also include the power differential in terms of different groups. New Mexico is a, again, majority minority state. We are a border state, so immigration is a big issue. In New Mexico, about 50% of the population is Hispanic. Of that group, about 90% are people like myself that have been there for generations. I'm a fifth generation. And about 10% are more recent immigrants from Mexico. We are largely a rural state. And we also know that there is, according to some definitions, more poverty in rural states. And let me just digress there a minute and say that from personal experience, I grew up and still live in a rural community, which is predominantly Hispanic and Native American. I did not know that I was, quote, poor until I went to do my graduate studies at the University of Denver. Because we didn't know that. We owned our own homes, we had land, we had a barter system. where we would exchange, a truckload of wood for potatoes or apples or chili. So, we were just fine. So I think that sometimes these definitions like majority, disparities, automatically tied to the word minorities, it's by whose definition? And I think sometimes it's well-intended, but can have impact on populations and on communities is a little bit misguided. And that's why we do all of our work from an assets-based perspective. There are both challenges and opportunities in terms of rural communities. Certainly, the current economic and political environment has implications in terms of healthcare reform, immigration, issues that are of particular interest to New Mexico and rural communities. Medicaid, we know, is a very important part of the health safety net, particularly, again, for children in rural communities. Geographic is certainly an issue. We are the 5th largest state. We all know which is the biggest state, but you can see on the map there, it's geographically from my office in Santa Fe to go to southern New Mexico and Las Cruces, that's a 5-hour drive. There is also a lack of infrastructure. It's kind of like wanting an automatic dishwasher in a house that has no plumbing. So whenever we can, we try to provide and support and increase resources for infrastructure. Then we have shifting demographics. We all know that our country is aging. In New Mexico, we're going to be going from 39th in the nation to 4th in the percentage of people 65 and older within the next 15 years. That's profound. Just imagine the implications of that in terms of our rural communities. And we all know that there's a higher percentage of elderly people in rural communities. We also are becoming more diverse. Now, New Mexico, as I mentioned, is ahead of the curve on that because we've always been majority, whatever that is. We always have had a higher percentage of people of color. So we're kind of a microcosm for the rest of the nation. I think that's an opportunity. Grandparents raising grandchildren. How many of you know that there is an increase in the percentage and number of grandparents raising grandchildren across the country? It is significant in New Mexico. Now, culturally and traditionally, we've always had that practice. Where I'm from, many of my relatives were raised by a grandparent. And it was part of the family, part of the extended family. It was looked at as a positive thing. What's different now, however, is that there's an increase in the percentage of parents unwilling or unable to take care of children due to incarceration, drug use, deployment. There's more people going into the service, including women, and that is having an impact on the families. So rural communities, I know there are challenges, but there's also lots of positives. And Tom gave an example earlier. I think Ashley, you gave an example of the ECHO program. Rural communities are very resilient and resourceful and innovative. So there are, we shouldn't just be doom and gloom when we're talking about rural communities. We have strong values in terms of, being community-based, family-based, intergenerational. The example I gave you in terms of grandparents, my husband and I raised our two nephews for a couple of reasons. And that is not uncommon. I see that as a positive, is that, you know, our kids are raised by other family members, including grandparents, and our kids don't get into the foster care system. How is that not a positive? In summary, some of the strategies that we have used successfully in terms of advancing and leveraging resources to advance health equity in rural communities includes the multi-field, multi-sector approach, private-public collaboration, the asset-based approach. So for example, in one part of northern New Mexico, predominantly Native American, we did not have enough nurses. So we went to a homegrown approach, and we recruited students from the community, started them on their RN studies while they were still in high school, collaborated with the university to pipe in the lecture part of the program, and helped develop resources for the field component. Now they have plenty of nurses, and they guaranteed employment at the local hospital. So that's an example, again, of how looking at the strengths, the assets of the community and supporting that. The last point is the community involvement. You can't have a community advisory group and marginalize them. And that's one of the biggest mistakes I think that groups use. It has to be authentic, it has to be institutionalized, and it has to be a way where that community voice is really the one that is contributing to the solutions. And that's what I think we are all about. Gracias.